Thank you for joining us for tonight's Grand Rounds update in partnership with St George Hospital. This is the final session for 2024, and tonight's topic is managing paediatric UTIs and abdominal pain. My name is Bertha, and I'm the CPD and Events Manager with Central Eastern Sydney PHN. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise a continuing connection to land, water and community, and pay respects to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues joining us tonight. Here's a list of the remaining events for 2024. For more information and to register for these, you can visit our website using the QR code on the screen. And if you need any support from our practice support team, you can contact the Practice Support Liaison Officer, the email on the screen, and that's a couple of examples of how they can best support you. So I would now like to hand over to Ivor, who is a nephrologist at St George Hospital and is part of the Integrated Care Chronic Disease Network. Thanks, Ivor.
Thanks, Bertha. Welcome, everybody. I'm not here in my role as a nephrologist, but just as my role on the team with Integrated Care. And it's really a pleasure to invite and have Donovan with us. Many of you will know Donovan, having met him in the St. George ED when other EDs. I know Donovan for many years. He trained and worked as a rural GP in South Africa, Canada, and then Australia, New Zealand before he developed an interest in emergency medicine. He then migrated to Australia and completed his specialization and commenced work at St. George as an ED staff specialist and acting director of trauma. He's got a long-standing interest in pediatrics and works at St. George. He also works at the Sydney Children's Hospital, and the P has got recognition for all those areas. So it's a great pleasure to welcome him this evening and look forward to hearing you talk. Thanks, Donovan.
Okay. So let's, I do have a few disclaimers. So firstly, let me just go back a second. Thanks for the invite. Ivor asked me about this about 5 or 6 months ago. It took a little while to come up with a topic, but I had a case the other day that sort of highlighted for me areas that I've been challenged by over a number of years. And I've put a lot of time and effort into them to try and improve them. And I'm still learning from them. And I thought that would be actually a good topic to bring up in this forum. I do have a number of disclaimers. I'm a very strong supporter of sensible test ordering practice, and I favor clinical medicine, and I do struggle a little bit with particularly hospital medicine it's drifting in a direction of multiple tests, and I think people are losing clinical skills. And I don't know if any of you are aware, but Choosing Wisely Australia is a very good website where each college has at least 5 recommendations that try and back up dogma or discredit dogma that we often practice by. I obviously learn daily, and as we all know, you're all experienced, and you'll know that you've been caught out a number of times. But I still think clinical medicine is the cornerstone of what we do, and we need to be good clinicians first. Just hearing the other day that COVID cost the country $343 billion, I think, made me shudder in thinking what we could have done with that money. And I'm not saying the COVID response was incorrect. I think we would do it differently a second time. And I think COVID divided people in lots of ways of how they thought about it was managed. But the fact that we spent that amount of money stunned me. And I know that health expenditure at the moment is heading in a direction that worries all of us. It's becoming exponentially greater every year as people live longer and need more and more expensive medicines and tests to keep them alive from cancers and immunotherapy, et cetera, et cetera. And so I do feel responsible for how I spend the health dollar. And so I am a bit, probably a little bit shy on the side of over ordering, and sometimes a bit critical of it. And I take that as a criticism of my own practice. But I do think hard about what money I'm spending, or whether it's doing much good for the patient and for the overall health system itself. There will be a slight bias in some of the cases I'm discussing that obviously talk about a patient managed in an emergency department. And I have worked as a GP for 7 years, so I recognize that my options for observing children and getting tests done are much, much, much different to yours. But I still think these two talks, or the points I want to bring out in this discussion, are learnings that I've learned from, and I'm hoping will be helpful for you in your environment. So what I'm going to do, just talk about some cases that I learned about at Sydney Kids, and explain why that came about, and then how we go about thinking about diagnosing UTI in children, the clinical considerations for requesting a urine test, how we get the urine specimen, how we interpret the urine dipsticks and the urine culture, and then just a little bit on abdominal pain and ultrasound base, or how we use ultrasound based on a case that we had recently. So I'd ask, and this is a talk I do modify for the staff I work with at Sydney Children's when they come for the beginning of the term, and say, do you consider getting a urine for analysis and culture in these presentations? An afebrile 2-month-old who's had 2 vomits, a 6-year-old with cramping epigastric pain, a 2-year-old male who's got a pyrexia of unknown origin for a day, and does the fact that he's circumcised change your decision? And a 9-month-old female who's got a 1-day history of a fever to 40 degrees centigrade but looks well. Now, the reason I bring up all those is because I would venture that a number of these patients in a number of emergency departments around the country and in a number of GP practices around would, and it's not unreasonable if they're sitting in the waiting room to say, can you get a urine on that child while we're waiting to assess them? But I think getting a urine without thinking hard about it and whether it really warrants a urine can end up with a lot of red herrings and issues to do with how we contaminate and create problems of our own, and certainly morbidity for the patient as well. I just wanted to clarify a few things while we're in there, because I think this is really important, something I always try and nut out with parents when they come in. And that is, what constitutes a fever? Because parents will often come to me and say, oh, but my kid's had a fever for 5 days. And then when you actually go through it with them, they don't actually have a thermometer, or they're using a forehead thermometer that reads 37.2, and they think that's a fever. Or they're using inappropriate instruments and not interpreting what it means. So what constitutes a fever in New South Wales Health currently for a child under the age of 5 is an auxiliary temperature greater than 38 degrees. And so I take this opportunity wherever I see a child under 5, and certainly the under 3-year-olds, to advise parents to purchase the cheapest thermometer, because everybody thinks the more you spend, the better parent you are, because they buy all the infrared and other things that cost a lot more than an underarm $5 thermometer. And then come in with these things, you try and look at the tympanic membrane of a 6-month-old and then think about what a tympanic thermometer is going to be doing in judging temperatures, highly likely to underread or not read properly at all. So I always explain to them that it's got to be over 38 and under the arm. Now, you know that, it's a controversial, because 37.5 under the arm, if you add half a degree, because there's often half a degree variance or less than core temperature, constitutes a fever of over 38. But a number of American guidelines and a number of other guidelines suggest 38.5 is really a fever of significance. And so I think New South Wales Health has decided that 38 degrees auxiliary, which represents probably 38.5 core, is what constitutes a fever worth thinking about and what to do. And it's really important, because that's often a trigger, for neonates to have a full septic workup. So you want to be sure that you actually are talking the same language. I've talked about that. And the next thing is duration and pattern. I'll often have a registrar come to me and say, oh, we've got this child that's had like 4 days of fever. I say, okay, that's interesting. And they go, I say, when did it start? They say, okay, Sunday evening. And I say, okay, we're talking today and it's Wednesday morning. So I get it, Sunday, Monday, Tuesday, Wednesday, 4 days. No, but actually Sunday night to Monday night is day 1. Tuesday night's day 2. And tonight would be day 3, but we're actually only 2.5 days in, but you're calling it a 4-day fever. Now, to me, it's a very different thing. A child with a 4-day fever is very different to a child with a 2.5-day fever. And I think the pattern is really important. So, the higher it is earlier on and coming and going, the more likely it's viral, whereas ones that start off slow and escalate and get higher and more sustained data are more likely bacterial. And certainly ones that start off with UTIs and a high start and start to decline over day 3, 4, 5, and then start to escalate on the latter days may represent a secondary infection. So I think you've got to be very good at soliciting a detailed fever history to understand what you think the pathophysiology is for that particular child. Just in that regard, and this will come more clear later, just thinking about the age bands, the way we think about UTI risk is now the less than 29-day-old, where UTI is the most common cause for serious bacterial infection, 29 days to 3 months, where again, UTI is the most common cause for a serious bacterial infection, but it's a lot lower risk overall, and other things are starting to come into play that we don't need to necessarily exclude. And then more than 3 months to toilet training is a big cohort in itself that are similar risk, but the younger they are, the more likely they are to have risks associated with the 3-month-old, and the more they are towards toilet training, the less likely they are. And I'll talk about that in more detail. And then the toilet trained child. So just clarifying some of those points. The next thing to think about is, would you send a urine for culture in these patients? You had a 5-year-old that came with fever and abdominal pain, and they have a negative dipsticks. A 9-month-old female with a pyrexia of unknown origin and a urine that was brought from home. A 3-year-old with an upper respiratory tract infection, which is rhinovirus positive, but a urine that is cloudy and smells like a UTI, but has a negative dipsticks. We'll talk about those because I often see someone rushing out and showing me a urine that looks incredibly cloudy, and they're shocked that there's no leukocytes in it. And you'll learn that pH and phosphates and other things that you eat can play a role in making the urine cloudy that have got nothing to do with the fact that it's got leukocytes in it. And similarly, there've been a number of studies looking at UTIs, and you can't get anybody to go nasally from one child to another and detect which one is the UTI by odor. So there often are odors to urine that may make someone suspicious something's wrong, but it's usually related to diet and other things rather than infection. And a 14-month-old female with a fever for 2 days, who's got a rhinovirus positive upper respiratory tract infection, but someone does a clean catch, and I'll put that in brackets, urine specimen on them, and they've got 1+ of leukocytes and no nitrites. So what I'm asking you to think about is, would you send these urines for culture? and again, by the end of it, I would say in our past practice at Sydney Kids, before we started to try and manage this a bit more clearly, a lot of these children would have exactly had these urines sent off, but it created a lot of morbidity, and we're changing that a little, and that's what this talk's going to be about. I just want to talk a little bit about the role of viral swabs, and I'll definitely say I've got a massive bias here, because I think they're a waste of money, and I'll tell you why. Because I'm on the phone Monday afternoons I do evening shifts, and so for the first 2 hours of my shift I have to check up results, and both patients and mainly patients can phone to get results of their children's tests that were done over the weekend from Friday through till Sunday, some of which are available, some of which are not. And that's where I started to learn about these urine cultures, because I'd be seeing all these urine test results and realizing that there was a lot of morbidity and wondering why we were doing tests. And the viral swabs have become the urine test of the past, because I never know what to say to a parent that phones me who had a viral swab on a Friday and their kid's still febrile, and they're quite happy with the fact that the viral swab has shown something. So it's interesting. I think we learned a lot about viral swabs in COVID, and certainly the public and doctors became obsessed with COVID swabs. But we all know the quality of the swab is highly dependent on how well it's done, how much mucus you get, how far back in the nasopharynx it goes, etc., etc. And we also know that they can be positive for weeks after the virus has actually stopped having any systemic effect on you. So that's why I struggle with the viral swabs we get today, because some can just be RSV, influenza, and COVID, and others can have every virus known to man on them, massive viral panels costing hundreds of dollars. And if I have a parent on the phone and they say, "Oh, can you tell me which virus is positive?" I look through a panel of 12 viruses and I say to them, "You know what? None of them are positive, but that doesn't mean your child doesn't have a viral infection." Because I've watched the nurses try and do the swabs on those, I've watched the doctors try and do the swabs on those kids, and I'm not convinced there was enough mucus obtained to say they don't have a viral infection. Or maybe the part that they swabbed wasn't where the virus was proliferating. That's the first thing. If it's positive, I say, "Oh, look, oh, great, your child's got bocavirus, rhinovirus, and metapneumovirus. Fantastic, 3. That's not my record. My record's 8 in one child, but 3 is pretty good." But I want to say something. I can't be sure that any of those 3 viruses are the reason for your child having their current symptoms. So we still need to be thinking, could your child have a secondary bacterial infection or another infection that's got nothing to do with that virus? We've had missed meningitis, missed septic arthritis from kids that have had positive viral swabs where then the parents are convinced that that's the reason the child is still unwell and don't get them reviewed. And doctors are doing the same thing. They're thinking, oh, well, if I got this positive swab, I can just rely on that. I think it's a big problem to have a positive swab that may not be the cause. And the reality is this: if I go into any daycare center right now and I stick a swab into all those kids' noses, I would be very surprised if every child didn't have at least one virus in their nose, and none of them are in my emergency department or your GP room waiting to be seen because they're unwell. So what does it mean if they've got a viral swab that's positive in their nose? To me, it means nothing. And, you know, as I said, what happens if there's more than 2 viruses? I've still got to be looking at the child thinking, I think you've got a viral infection, but what are the things that make me think you could be secondary bacterial, and how do I look for that? And as I said, the thing about the daycare centers, what's the asymptomatic prevalence in this age group? We don't know. It's very hard to know. And I'm not even going to go into mycoplasma because that's exploded. But certainly the ID physicians have been telling us really hard, stop testing for it, stop looking for it, and stop treating it unless they're in patients that have got significant complications, need to be in hospital. Don't treat positive swabs. But that's a discussion that's not for today. But I'm just saying these are just things that, you know, they're just a sort of pattern of behavior that begins and it gets followed, and we don't sit back and think, what does it mean? Anyway, so I'm going to just give you a few of the stories that I experienced on these Monday afternoons, which made me take an interest in this area. So 5-month-old female was seen on a Sunday night with a fever without source. Someone was smart and did a catheter urine analysis, which is pretty invasive. And for me, they've got to be sick enough to do that, which is, you know, one of the least contaminated methods you can do. And the urine was sent off and had an MCNS that was negative. So the reason I know that is because I saw this child on the Monday. They came on the Monday and I saw them. The discharge at that stage was maybe viral, the negative UA. And that's a totally reasonable way to approach this child, because that's the most likely cause for a serious bacterial infection if it isn't a virus. Child came back a day later, looked more unwell, still febrile. And I was worried enough that I thought, this child looks grottier than I'm expecting for a virus. And I did some blood tests and they had a high neutrophil count, a high white cell count. Couldn't locate an infection. Thought I'm going to treat them for strep pneumonia sepsis. Admitted them into the general pediatrician on Ben Penn. And that was the end of the story. The following week, I thought, oh, let me just see what happened to that child. And I saw a discharge summary that said UTI. I was like, no, but I know this child. They had a negative UTI, negative UA. What happened? So I looked through the notes, and what had happened is the parents had been sent home on the first night with a specimen jar and told that if the child's still unwell, to come back with a second urine specimen. And the parents had collected that at home and brought it in, given it to somebody clerical at the front desk, who'd got a doctor to say, hey, this child, you know, got a urine brought back, can you send it in? Urine had been sent in and no doubt contaminated, which I'll talk about later. Now, the inpatient service would not have any idea of that. They would just be looking at results as they came through and say, oh, gee, well, the second urine's got a E. coli. This child's got E. coli. And so this child was, now the thing is, if you diagnose UTI in a 5-month-old female, that child's next 2.5 years are tough. Not only are they going to have ultrasounds and things to start with, but every time they present to you or us in the ED with a previous history of UTI, the vigilance and need to try and exclude it every time they have a fever goes up. So a lot of morbidity comes in over there. And so that was just one example of a case. Then I had an 8-year-old female fever, headache, bilateral loin pain. The treating clinicians thought viral, maybe UTI. The UA had a negative dipsticks. And an 8-year-old, they should give you, good symptoms of things leading up to, pyelonephritis, and pyelonephritis almost never bilateral. But it was sent for micro. The patient was discharged. I was looking through the micro on the Monday, and I noticed it had E. coli grown, but it had no white cells and looked very suspicious for contamination. So I thought I'd just phone the family, because I have to tell them results positive, but have a discussion with them about, what's going on. And they said, no, we'd spoken to the local doctor who's also checked the urine results, and we've got a diagnosis of UTI, which is totally reasonable that, anybody would do that. And we're getting some antibiotics and we're going overseas tomorrow to India. And I said, well, tell me what else is happening. He said, oh, well, yeah, she's still got a headache and she's still vomiting. And I was like, what about her back pain? I said, no, she hasn't got back pain anymore. Anyway, I brought her back home. I brought her back to ED. I said, can I just have a quick look at her, please? Brought her back home. She had meningism. We did an LP and she had meningitis. And she was about to go overseas on Keflex for a UTI. These are all true stories. 6-week-old female, male, 2 vomits. Now, to be vomiting from a UTI at this age, you pretty much got to have pyelonephritis with a fever. So I've stopped trying to check for UTIs in every child that vomits. There's multiple reasons children vomit. I'm not saying UTIs aren't one of the causes. but I certainly want more bang for my buck in symptoms to suggest that I need to exclude a UTI on any child that has a couple of vomits. Because most of these little babies come in, have a couple of vomits. It's usually because of overfeeding or maybe something contaminated on the teat or the nipple or whatever, and they have a couple of vomits, they pass a trial of fluid, they go home and they're well. But if you do a urine in the in-between, you'll often get a contaminated specimen unless you do something invasive. But they're young and they're frail and you don't want to do something invasive. So you get a dodgy specimen, which gives you a contaminated specimen. So that's exactly what happened to this child. Somebody tried to get a clean catch, and who knows what it was like. I go to look at the culture 2 days later. I've got a 6-week-old male that says the culture's positive. I look at the specimen, there's no white cells, which should go along with the UTI. The child's never had a fever. I call the family and they say he's well at home, feeding, hasn't had another vomit, he's been well for 48 hours. We had a good discussion about backwards and forwards, what does this mean? And I was quite happy to do nothing, but they were very anxious, the family. And so they came in and I had to do a suprapubic aspirate on this child to prove they didn't have a UTI, which I didn't enjoy doing and they didn't enjoy seeing, but that was the only way they were going to be happy because they were very anxious. But if we hadn't done it in the first place, it wouldn't have had to, go this way. This was one of the hardest ones I found. A 5-year-old female, cramping abdominal pain. This is quite embarrassing for our department. Vomiting 3 times. Now, to me, these aren't symptoms of a UTI. It wouldn't enter my head. I'd go and ask her, have you wet your bed? Have you got burning in the urine? Yada, yada, yada. But she had none of those. She had 1 loose stool. She had no fever, normal clinical exam with a soft abdomen, but someone asked for a urine, and there was a trace of leukocytes. And we'll talk about the relevance of leukocyte counts later on. So the UA was sent off for microscopy, even though for me the clinical situation wouldn't warrant that. And because the urine showed a trace of leukocytes, the clinician looking after them decided to diagnose UTI and put the child on Keflex.
Donovan,
yep.
Sorry to interrupt you. People have just asked if you can just, at the end of the story, just hold on and maybe let people ask a few questions, because they're quite keen after you, just to discuss it.
Sure. Look, I'm very happy to do that.
Are there any questions at the moment now for anyone, for Donovan?
Because I'm going to clarify what all these cases mean, just so you know, and how we got to that. But very happy to talk. There's a chance we'll go over time, but that's up to you if you guys are happy to go over time, because I'm very happy to, obviously, I don't want you to leave without having questions asked, and I'm very open to answer.
Okay, so if anyone does want to ask a question, please just type it in and I will interrupt Donovan.
Yeah,
Thanks.
apologies. It is, and I do talk fast. I know that. I'm hoping they're just stories at the moment, and it's hard for me because I can't see any faces. I'm talking to a screen. Anyway, so this child was diagnosed with UTI, put on Keflex, sent home, came back 2 days later, ongoing abdominal pain, waking the patient from sleep. The urine that had been sent off on the first day had grown strep pneumonia. Now, that's a very uncommon cause of a UTI. Most likely someone had their fingers in their nose and then was, holding the bowl when the child peed or something like that. And there was, again, no pyuria, no white cells in the urine microscopy. But the treating clinicians were reassured and said, yep, no, you have got a UTI, keep going with the Keflex, we're on the right track. Child came back after 2 more days, more abdominal pain, more vomiting. The repeat urine that had been sent off was negative for everything and no culture. They decided to diagnose it as constipation, put on aperients, further UA taken, this is the 3rd one, and sent. So I saw her on her 4th visit. The father was livid because this child hadn't slept and was cramping in pain. She was moderately unwell, doughy abdomen. I did some blood tests on her because of concern whether she had a delayed perforation of an appendix and maybe a small phlegmon or something in her abdomen, but she wasn't focally tender or something else. But she had a very high eosinophil count, and when I went through the story, it did sound like an insidious kind of gastro and more likely giardia. And I put on metronidazole, and she got better in 48 hours. But I was just horrified at how this all started because of an incorrect UA, and the premise of the UA was a story that to me didn't really fit with the UTI. So
Donovan, Nancy's asked a question about that case. The urine test was negative, but were there any criteria suspicious of a UTI?
No, because they weren't. So in this case just gone by, there was no dysuria, no nocturia, no back pain. And it was just cramping epigastric pain with 1 loose stool and intermittent vomiting, which to me doesn't fit with the UTI. But what often happens, and it might happen in your practices too, is, if a child's in a waiting room and then you've got a busy practice running, you'll say to the nurses or whoever, or the parents, hey, while you're waiting, do you mind if we might need a urine on your child rather than going and peeing and then we can't get one for the next 3 hours. If your child needs to pass urine, could you get a urine specimen for us? But then sometimes we don't think about what the specimen means in context of the presentation. So I'll go and see a child and say, yada, 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 oh, and someone's done a urine. Actually, I'm not interested in that urine because it's got nothing to do with the story. So I just put it in the bin. But what I'm saying is some people get red herringed by what the urine result shows when it has no clinical context. I hope that answers the question.
So then there was also a question here about the Giardia and how it was diagnosed. What tests are usually used to make the diagnosis?
Okay, look.
What evidence was there for Giardia?
Yeah, good question. So look, I always find this an interesting area because I work with a number of colleagues who don't. I think a few of them I've managed to bring over my way, but it's how do you diagnose Giardia? Well, it's theoretically, and again we're getting off topic here, but theoretically it's one of the most common causes of travelers diarrhea in the world. I think if any of you have traveled, and even within Australia, I think a number of years ago, Sydney water was contaminated with Giardia. And it's, a lot of the viral and salmonellas and shigellas and other gastros tend to be quite fulminant in the beginning, with florid watery diarrhea 10 times a day, yada, 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 will last 3 to 5 days, not considered chronic unless going on for more than 10 days, 2 weeks. And often if you do a stool, you'll pick up a virus, rotavirus, whatever, norovirus, something like that.
Okay.
I find Giardia, Giardia tends to be,
I finished the Giardia. That's good. There's two other questions here as well.
Oh, we won't get through anything.
Okay,
but
so I'll
it's not
just
really
go
finishing.
quickly. Maybe you can answer them along the way.
What I'm saying with Giardia is it's an indolent, and often I'm faced with a child that's had days of abdominal pain, and I don't think about it after 3 or 4 days. I'm talking about like 10 days of abdominal pain and odd vomit, a bit of loss of appetite, a bit of loss of weight. And one of the doctors will say to me, oh, by the way, this child, I don't know what's wrong with him. And I say, anything you've done? I've done a white cell count, it's normal. And I go and say, let's have a look. And we have a look, and there's a neutrophilia. There's an eosinophilia there. And so eosinophilia, can often represent parasites, can represent worms too. But I have a very high success rate. Just anecdotally, I've kept a record of these, and I phoned them up on just treating those with 3 days of 30 milligrams per kilo of metronidazole for 3 nights as a potential Giardia. So that's the Giardia question, but it's not the focus.
Great, thanks, Donovan. Just GPs were asking, should GPs be doing in and out catheters in the room?
No.
And how reliable is a false positive on a clean catch urine?
Okay, so these are just stories. I'm going to go through all of those.
Great.
So the nuts and bolts of how to approach this is coming up after these stories, but it's just to show you the morbidity that goes along without thinking about it. I am giving little anecdotes and I am hinting at stuff, but I'm going to cover it comprehensively in this talk.
So I'll stop now, and then just one last thing. They are asking also about the leukocytes and the nitrites and what they all mean.
I'm going to cover all of those.
Okay, so great.
I'm just talking generally about cases and the morbidity that I've experienced, and this is still going on all the time. And then I'm going to go through exactly how we go through deciding who we do what on, when you do in-outs, when you shouldn't, yada, 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 all of that. So I'm going to cover that very comprehensively in a minute. This is just a number of cases first. Then we're going to go through how we diagnose UTI. But the relevance is understanding the morbidity that comes from not thinking about it. And that it's for me, when I trained, I thought it's a piece of pie. Just get a urine off anybody that shows something, treat. But for me, it's not that anymore. It's thinking hard about it. And I'm going to come to that in a minute.
Right.
So
Thank you.
I do appreciate your patience, everybody, and I understand I'm going quickly through these cases, but I just wanted to highlight some of the issues, and so you understand where I'm coming from. So this was also a pretty interesting case, a 10-year-old female. She was referred by a pediatrician in the eastern suburbs with multi-drug resistant UTIs. And the request from this pediatrician was, could I please admit this child on IV antibiotics because there were no oral antibiotics available that could treat this UTI. Child came in, I saw them, they looked well. They had no symptoms of a UTI, nothing. This child initially was diagnosed with UTI when they were 5 years of age. And at that stage, they were found to have larger than average post-void residual volume. Other than that, the renal tract of this child was normal. And so, most kids that are going to have posterior urethral valves and vesicular urethral reflux and other anomalies that put them at risk of UTIs will present usually in the first 3 years of life, if not early, first 3 years of life. So it's unusual that this child was diagnosed age 5, and it's hard to know. Again, we know that probably 2 to 3% of children do have small post-residual volumes now, but I guess in the context of this UTI, that wasn't a urological finding on ultrasound. And because this child had this UTI, which was a pyelonephritis, the mother had become hypervigilant, and that's not unusual. I've had a number of patients like this where people are worried, and it became evident that this mother basically had a bank of pathology forms, and every time she thought the child was unwell, she would get a urine and send it off. And I'll show you the evidence by that, but I had a good discussion with her to read all this out. But a lot of the time, it was if the child had an itchy toe, she got a urine sent. The specimens were obtained at home, they were dropped at the GP, and then the lab would pick them up from there. And the average time was at least 4 hours before they got to the lab. And that, again, all of this will become relevant when I go through why it's important to think about how we get specimens and how we choose and how we store and how we send, how we interpret. And there were multiple different organisms cultured in her urine on all the different types of culture. I looked at cultures over 4 or 5 years, and on average, you'd have like 14 cultures positive a year, which was crazy. This was the one on that particular day. And what I want you to notice there is on the top, it sort of says, oops, it says that you can see she's got a form there that goes back from February, that the urine was collected sometime around 9 a.m. and received at the lab at 12:28. And then 2 days later, this result's printed. In this case, to be honest, if this was a person with good story, she's got a high white cell count, there's no epithelial cells, there's a very good high count of E. coli. It may represent a UTI with the right story. But what you notice, the main thing here is all these resistances to multiple different organisms and multiple different antibiotics made it very, very difficult to manage her. So she's likely got chronic asymptomatic bacteriuria. She's having non-indicated specimens. The specimens are not collected well, they're not stored well, and then the interpretation of the micro is probably not looked at hard, and she's having inappropriate treatments. And at the age of 10, she's got multi-drug resistant organisms in her urinary tract. And that's a big problem for this young girl. There's nothing on the horizon for her if she actually gets a proper ascending infection. So, right. So what's the problem? And why did this get to me? And why did I take this on as a project? Because I realized UTI has been suspected with little consideration for clinical likelihood. That we get urine samples without thinking about their indication. We are not clear how to collect them properly, and we often collect them suboptimally and get specimens that aren't ideal for analysis. We don't review the dipstick screening tests in context of what the patient comes with a sore throat. It's probably not relevant to have a urine unless you're looking for proteinuria and post-streptococcal pulmonary or something. But you shouldn't be doing a urine on a 12-year-old with a sore throat, for example. And the screening tests are often diverting people away from what the child's really come in with and resulting in premature diagnostic closure that this child's got a UTI. And there are a lot of false positive and unnecessary negative tests that are responsible for a lot of morbidity, cost, and inconvenience. And this was driving me crazy. So we'll talk about now how to go about thinking about diagnosing UTI. So the first thing is, what does it encompass? Well, in a child, balanitis, urethritis, cystitis, pyelonephritis all fall under the banner of pyelonephritis. I'm sorry, of UTI. But if you're saying you're looking at a febrile child and you're saying you think they've got a UTI, the UTI they have is pyelonephritis. So the child in front of you with 3 days of a fever that you want to do a UA on, that's running around your emergency department or your rooms, you have to think, look hard and think, does that child look like a child with pyelonephritis? Because balanitis, urethritis, and cystitis are generally not associated with fevers. In fact, the bladder, although you can get hemorrhagic cystitis and it's obviously irritant, is very resistant to invasive infections, whereas the kidney is obviously highly vascular and very vulnerable to invasive infections. And that's why fever in children with UTI, if you're thinking UTI, suggests they've got pyelonephritis. And that definitely changed the way I thought about looking for UTIs in children. And with that, if this pyelonephritis is going to cause discomfort and vomiting and high fevers and a blood count of 18 in the blood test that someone might do, then there have to be white cells in the urine. But people seem very happy to diagnose UTI without any white cells in the urine. But there's got to be white cells in the urine. And I'm not going to go through the cause because you all know about it, but most of it's around ascending and the anatomy of male and female and some of the anomalies. Urine composition and flow is what defends, provided you've got good flow and you've got acidic urine, you tend to defend your urinary tract quite well. Some organisms tend to be, particularly E. coli, adapt quite well to attaching to the bladder epithelium and can become quite difficult to eradicate. And, in babies, there can be septicemia that happens to lodge in the kidneys and become a pyelonephritis, but it's actually began as a systemic infection. What are we worried about? Well, we're obviously worried about localized infection, and it's horrible to have dysuria. We don't want them to progress to something worse. We don't want them to have recurrent infections. We're worried about invasive infections that become from pyelonephritis, particularly if people get bacteremic and septic and renal scarring. We're obviously worried about mortality, although, and we're never going to push this point and get to that point, but mortality overall in urosepsis in babies and children is rare, but it's still a very unpleasant and scary infection. Now, renal scarring, when I trained in South Africa when I did my PEDS term, that was the big thing. If you missed a UTI, you were condemning this child to lifelong kidney failure and dialysis and things like that, and everybody was paranoid about missing urinary tract infection. But things have changed a lot in that regard. Early studies that had patients that had, and this is Ivor's area of speciality, so he can definitely correct me, but the number of patients that were found to have chronic kidney disease were noted to have had recurrent pyelonephritis in their earlier years. And it was purported that perhaps it was the recurrent infections that had caused this chronic kidney injury. We now know that it's much more complex than that. That most scarring is related to obstructions, high-grade reflux, a lot of genetic and developmental factors, kidney hyperdysplasia, and on top of that, pyelonephritis can contribute. This has been reaffirmed by the fact that there's often evidence of scarring in the antenatal part of development, and that a number of children's scarring progresses without any documented infections. It's still really important to surgically correct and prevent recurrence of infection, as we would for any infection. And longitudinal studies that have now looked at up to 30 plus years demonstrate that there is not a lot of significant renal dysfunction or hypertension in adulthood from children that have suffered pyelonephritis as babies, and that even those that had bilateral disease, and it was very rarely just pyelonephritis, it was usually a combination of the things I've mentioned before, had small measurable decreases in EGFR, but they certainly weren't people that end up with renal transplants. So I think the scarring side, paranoia has changed a lot. There's a lot of other papers, looking at how many days of pyelonephritis can you sustain before you start to develop scarring, et cetera, and therefore how aggressive you should be. And most people agree you can probably wait up to 3 days to diagnose UTI before you need to worry about whether it's going to have any significant injury. But that's, again, not for here. So we're worried about their infections, worried about them progressing to septicemia, bacteremia, and we're worried about scarring, but it isn't what we thought it was. So if we want to avoid all those things, we certainly want to make sure that we diagnose UTI and look for it in the appropriate patient to make the diagnosis correctly. So for me, these are the cornerstones of how we go about that. We're going to talk about all of them. We've got to have a good clinical suspicion. And to do that, you've got to sort of understand what the UTI rates are for certain population groups and what their risk factors are and what clinical features in each age group might support the fact this child has a UTI. We need to think about how we collect urine specimens in each age group, what the methods and merits and limitations are of each method, and how they should be stored, and an appreciation of what the likelihood of contamination is for each of those collection methods. And then we've got to think about how we interpret the urine dipsticks and how accurate it is, and also how we look more closely at the microscopy and culture results that come across our desks and think, is that really a UTI? Not just because it cultured something. So age is the big one. I've already said to you, I'll just cover it very briefly, but you know, if you look at febrile children and fevers without a source, the chance of having a UTI, if you're under a month, it's about 8 to 10%. Interestingly, the highest incidence there is uncircumcised boys at about 20%. Circumcised boys are more 2%, and girls in that 8 to 10% range. So your biggest chance of picking a UTI in a febrile child is in the neonatal period, up to 28 days. Between 28 days and 3 months, it drops a couple of percent. And you can actually use clinical acumen there. There's a number of studies that show that if you can't find a source and the child is toxic, you should be looking for a urine. But if you've got a recent vaccination, a runny nose, and the child looks well and non-toxic, you can wait. And UTI rates in those two populations correlated quite well with clinical impression. So you can start to use clinical impression in the 1 month to 3 month olds. Now, I'm not expecting all of you to be doing this because, you know, I'm looking at kids for 20 hours twice, 20 hours a week. And, you know, you'll have a child come through in these different age groups once a week, once every 2 weeks. And I'm not expecting you, I'm just giving you the numbers. I'm not expecting you to be doing investigations and thinking hard about them. I'm just giving you the numbers to think about whether you send these kids for exclusion of UTI, or you think about excluding it yourself or not. So having an idea of the incidence does help. So as you can see, as you get older and older, and certainly once you get to toilet training, which most kids are around 3 years of age, the incidence drops much lower. And so looking for it, you really need to have more suspicion or more symptoms. Females always greater than males. When males come, uncircumcised males more likely to have UTIs than circumcised males. White females, highest incidence compared to black females. In other words, Caucasians got the highest incidence of UTIs. Generally, we don't need to exclude a UTI on day 1 or day 2 of a fever. If a child's had a fever going into day 3, more than 48 hours, and you haven't found a source, then you might think about looking for a UTI. The reason is if you start looking on day 1, you're going to miss all the kids that end up vomiting a day later or having diarrhea or getting a rash, suggesting a virus, or a runny nose and a cough, and all the things that come out suggest they do have a viral infection, but not a positive swab, in my opinion. So in general, if I see a well child with a fever on day 1 or day 2, and then non-toxic, then I would not necessarily do a urine in that child. But if they're toxic or unwell, or if they've had 3 days of fever, and I think that, you know, I'm not confident of a source, I'm quite happy to look for a urine as a source in that child. Generally, any child who's febrile with a prior history of UTI or anatomical predisposition, and that's why it's important to be sure you make the proper diagnosis of prior UTI and you don't put them in that box without being sure. But those with anatomical predispositions, it's very important that we do think about screening them. Now, interestingly, if you think about the oncology group, it's very rare that UTI is the cause of febrile neutropenias. And that's mainly because the urinary tract is not defended by neutrophils unless it overcomes your basic immune system in your urinary tract, which is, as I said before, acidic urine flow. So as long as you're passing urine, no anomalies, no prolonged stasis, and it's acidic, you're unlikely to get a UTI, even if you're immunosuppressed. It's when those things are overcome that you may develop a UTI. If I think about all the febrile neutropenias I see in the ED, it's just, I can't think of the last time one was ever diagnosed with a UTI, adults and children. And then obviously a child with clinical features, dysuria, nocturia, polyuria, loin pain, that fit with the UTI, not cramping epigastric pain, I would think about doing a urine. So what I'm saying here is there's a number of things to think about that increase your clinical suspicion that this child might have a UTI, and it's reasonable in that group to say, I want to do a urine on this child to analyze it. What I need to do now, though, is make sure I don't get a contaminated specimen that's going to mix up everything and give me a false positive or false negative results. So I need to be sure. So there's a woman, I can't remember her name right now, in the US that does a lot of work on this, and She publishes quite widely, and she's got some little algorithm she's got there where you can just plug things in, a little bit like MD Calc, and it'll give you a number. And this is an example of something from her work where, if you plug in these sort of things, you can see this female, fever for more than 48 hours, greater than 39, yada, yada, yada. 16% chance of UTI is the source compared to the male, because normally that age child would probably only be the 8 to 10% range, whereas the male, less than 39, less than 48 hours, yada, 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 who's black, circumcised, has got rhinitis, got a 0.1% chance of UTI. So, but I would venture that a lot of those kids, if I see those two kids coming into my emergency department, they both have a urine asked for, because people wouldn't think about the relative risk of a UTI in that particular child. And so there is a lot of background risk assessment you have to do, which can be challenging if you're not doing it all the time. And I acknowledge that, but I'm happy to take questions later. We'll talk about it. So that's the group. That's how I think about who's at risk, who am I going to do a urine on. Now, we'll talk about how we get urines in a second, but the next thing is when you get the urine, how do we analyze it? And I think there are a number of people that have been asking that already. So the first thing to know is the leukocyte esterase is helpful on the dipstick, and I actually find it more helpful sometimes in the micro, and it explains why. But it does depend a lot on the fact that your machine works well and that your dipstick strips aren't destroyed. So negative represents less than 10 white cells per microliter. A trace is 10 to 20 white cells per microliter, and that can be considered physiological. Once you get to 1+, it means there's more than 20 white cells per high power field, but less than 50, and this begins to be pathological. 2+ is 50 to 100, and 3+ is greater than 100. And that's considered pathological. But pathological doesn't mean the white cells are coming from infection. They can come from a number of things, and not necessarily from infection, as you'd know. But why is that important? Well, I find it helpful because my microscopy, as we'll show you in a while, and I'm sure it's the same in your lab, only gives me 3 ranges: less than 10 being negative, greater than 100, which is 3+, and all the rest are bulked into 1, 10 to 100. So it could be somebody with 15 who's in the 10 to the 100 range. And that 15 wouldn't mean as much to me as someone with 95. So, because obviously the higher the white cell count, the same as a neutrophil count and a white cell count in a blood test, the higher the white cell count, the higher your suspicion that this is a true local infection causing cystitis, pyelonephritis, etc. But as I said before, just having positive leukocytes does not mean that you have infection. You still have to think about the relevance of the presentation and the other factors. But that's where these leukocyte esterase tests sort of correlate with microscopy and help me a little bit in working out how positive I think this dipsticks is. Now, there were lots of talks about nitrites, which I'm going to deal with now. So I think about pecking order, which reminds me of Proteus, E. coli, and Klebsiella, meaning you go to the top of the pecking order if you have those 3, because that just tells you what positive nitrites, those 3 organisms cleave nitrates into nitrites and produce them. And then there's Enterococcus faecalis and other Enterococcus species and Pseudomonas that don't. So just having nitrites tells you might have one of those 3 organisms. Doesn't mean they're pathogens, though. The problem is you can have a lot of false positive nitrites. If you look at the stick, it's a very small tinge of pink that makes it positive. And hemolyzed blood, dehydration, certain pigments can make it a false positive. And if the urine doesn't sit in the bladder for long enough for the organisms to actually metabolize the nitrites or produce the nitrites, you can have a false negative. And that's the problem with young babies, because they drink milk, pee, drink milk, pee. It's like every hour or 2, hour and a half. So often negative nitrites and low white cell counts are not particularly helpful in under 3-month-olds because they have such a quick urine turnover and their dwell time in their bladder is short. And I'll talk about that in more detail, but that can be a reason for false negatives. Red cells are interesting because they're definitely not one of the diagnostic criteria for UTI. They may accompany UTIs, but they are not commonly accompanying UTIs. And I think it's important because people do get sent in with glomerulonephritis and hemolytic uremic syndromes with red cells being diagnosed as UTI, because of the red cells. But they're not a common accompaniment of a UTI. Now, the thing about the dipsticks, as I said before, there are a number of considerations with those things I've mentioned, both the positive leukocyte esterase grades and the presence of nitrites, which I'll deal with in more detail in a second. And that is because young babies, particularly under 3 months, have shorter dwell times, their white cell count on nitrites might not be positive enough to excite anybody looking at them, but they may still have a positive UTI. So in general, if we go to the point where we think a child warrants a urine, which is normally invasive in an under 3-month-old, we will send it. Urine storage is really important. So ideally, once you've taken the urine, if it's kept at room temperature, it should be in the lab and plated within an hour. If it's going to take longer than that, it should be refrigerated at 4 degrees, but it shouldn't be refrigerated for more than 4 hours. Ideally, it should reach the lab within 4 hours at 4 degrees centigrade. And why is this important? Because of growth. So if you had a florid E. coli UTI right now, and I took a urine specimen from you, if you had a pyelonephritis growing UTI with E. coli, and I took a specimen from you now and took it to the lab, and they put it on a plate, and it started to grow, tomorrow morning there'd be 10 to the 8, greater than 10 to the 8 little high-rise buildings of E. coli growing there, and white cells to support the fact that this is a UTI. If I took a urine specimen from you and you didn't have a UTI, but it was a small contaminant from the perineum, so it wasn't growing fastidiously in the urine, and I sent it to the lab and they plated it within 1 hour, first of all, the next day the microscopy wouldn't show any white cells. And maybe after 48 hours, they'd say, oh, there's a growth of E. coli, but it's 10 to the 5. It's growing, but it's not growing fastidiously because you've sent it like that. The problem is, if that second specimen that I mentioned, that is contaminated with just one little organism of E. coli not growing fastidiously, is left at room temperature for 4 hours, that E. coli starts to grow in that urine specimen. By the time it gets to the lab and it gets plated, it's going to grow at 10 to the 8 and look like a pathogen, but it's in fact a contaminant. And that's the problem with getting specimens from people from home, is they don't pay attention to hygiene in procuring the urine, and they tend to just get it as a convenience, and they take it in when they're ready. And those specimens can stick around for days before they get brought in. And then they grow all sorts of things and create a problem. So storage is really, really important when you try and interpret these things. You may have to make sure your analyzer is calibrated and looked after. And strip stress. So I often say, what's wrong with this picture? There's 2 things wrong. One, you should never stick the dipstick directly into the urine. You should get a sterile syringe, take a specimen of the urine and run it across the syringe, across the dipsticks to get your specimen. And 2, you can see that the bottle is sort of left open there. There's dipsticks sticking out of it. And the problem is these dipsticks will both oxidize. Humidification, oxidation damages the sticks. So if you get strip stress, then you can't rely on the test. So people often run up to me and say, Donovan, oh, we got this guy, he had a negative dipsticks, and then he grew E. coli, and he was, we thought we could rely on the dipsticks, and I go into the room and they're sitting there without the lid on for 3 days. So, tests are only as good as how good the material is we use and how well we look after it. All right. So in general, what do I think about how to interpret dipsticks? If it's negative on a child more than 3 months, because we've covered the under 3 monthers, then they're highly unlikely to have a UTI that's responsible for their fever 39 degrees for 3 days. And I've mentioned already, odor and appearance do not play a role in diagnosing UTI. If it's positive on a child greater than 3 months, then your UTI likelihood is very dependent on their age, as I said, because it'll depend on what the history is like and the dipstick's findings. So this is the way this is just a rough example of how it works for me. These are numbers sucked out of my thumb, but it's just to demonstrate something. If I had a reasonable story for a UTI on a child and they had a 1+ of leukocytes, they might have a 25% chance of actually having a UTI. If I add nitrites to that, it might go to 35%. So the specificity sort of increases if I add nitrites to my leukocytes. If my leukocytes in that same patient where I'm suspicious that they have UTI are 2+, my UTI incidence might be now 50%. And if I add nitrites to that, it might become 65%. If I have 3+ of leukocytes in a good story, it might be an 85% chance of a UTI. But if I add nitrites that are positive to it, it might be a 95% chance of a UTI. But why I say that is what's important is if you have no white cells and only nitrites, it's not a UTI. The nitrites do not have value if there's no white cells, because the white cells are the basis of the inflammatory process that's causing the fever, causing the symptoms. And if your source is urine, there have to be white cells. Nitrites on their own are likely to be a false positive. So I only regard nitrites as having any value if they're accompanied by white cells. Again, with the appropriate story. We've spoken about why dipsticks is not helpful under 3 months. But if you've got a 3-month-old and you do an invasive urine and it's positive, you can usually decide to treat based on that, which is different from if it's negative, where you might still get caught out and might still be a UTI. Just remember though, if a dipstick is positive on any child, before you send it, consider all those things. Clinical risk, what's the mode of collection, could it be contaminated, how positive is it, how high are the white cells, how are the nitrites, as I've spoken about, these other factors. Just briefly, this is what's published. Clean catch urines and midstream urines have about a 25% contamination rate. Those bag specimens we used to put over perineums and then wait for people to urinate into, they're good for other things, but not for they have a high contamination rate, much lower for catheters and lowest for suprapubics. And female contamination by anatomy and trying to obtain a clean catch from a non-toilet trained female is almost impossible. And the least contaminated are the circumcised males. Ivor, did you want to ask a question and stop me there?
That would be great to finish off with a few questions. Thank you, Donovan. It's always
I've got more to go, but did you want me to stop soon?
Yeah, I think it would be good if you can just finish off so we can maybe have 1 or 2 questions. There's a few that you could probably pack together.
Okay, let me just get to the end. Just remember, if you analyzing balanitis or urethritis, people often ask for midstreams. You don't want a midstream in that group. You want the first pass. And teenagers need other things. I'll just go through a very brief case to show you an example of stuff. Actually, let's just stop there, and I'll just say this much, that to diagnose a UTI, the culture has to have a colony count of greater than 10 to the 8, presence of pyuria, and the definition therefore overall is it's diagnosed with an appropriate growth of a single likely organism in a patient that has a fever if they're an infant, or in children that are capable of telling you symptoms and the presence of pyuria. So I might take some questions, then I'll just do a quick summary.
There were a few questions about the labs just not some labs not taking urine off, that they collect them quite infrequently, and so as you mentioned, there's a higher likelihood. There was also some questions about some E. coli being sensitive to trimethoprim and then resistant almost on the same specimen. So there are these confusing aspects. Do you have any sort of suggestions in principles just to follow? And the best way to collect urine.
Yeah, I think I was going to talk about the best way to collect urine. I think I mentioned that back here. I'll just go back a second. So in under 3-month-old, suprapubic or catheter for all, except for maybe a circumcised male, which is not common. 3 months till toilet trained, what we would do is tell the parents how to prepare the perineum. So give them some saline and a wash, and they just wipe the perineum to make sure there's no stool and things, maybe even just the standard baby wipes, but just to make sure the perineum's clean. We don't mind putting cotton wool right up against the urethra and let them pee in it. And if the dipstick is negative on that, then you can consider that you've excluded a UTI. If it's positive, you then got to look at how positive is it, and then how worried am I? Should I now consider invasive sampling? But screening like that, just with cotton wool in the nappy, probably reduces your rate of asking for urines in the 3-month to toilet trained by about 80%. So it's a good thing to think about, because you'll often rule out UTI by having a negative dipstick in a contaminated specimen, because it isn't a perfect specimen, but it's just them pee on the cotton wool. And then once they're toilet trained, then you get the parents to prepare the perineum and try and get a midstream. But I would still say beware of the 4-year-old female, because I think they often get the urine scraped off the perineum. So you've still got to make sure I always ask them, when I've got the specimen, how did you get the urine? Just explain to me how you got the urine, because I don't want to phone them in 2 days' time and say they've got E. coli and start treating them when in fact the specimen wasn't obtained correctly and the child's well.
That's great. So look, I think there's a huge amount of interest in this area. There's 18 questions. Perhaps some of them you could look. People really liked your summary slides, and are hoping that you'll be able to make them available. And I think you've got your last summary just to finish off.
Yeah. So apologies for going over time. I didn't get around to talking about ultrasounds, but and it's a pity we just can't have a conversation, because I'd be very happy to take questions and just chat. And I'm very happy, I'm on Donovan.Dwyer at health.newsouthwales.gov.au for you to just email me questions from today, and we can have a discussion around this. It's obviously an area of interest of mine, and I've spent a number of years inside it. And so I do have biases, and I'm not saying it's easy for you, but essentially the summary is, for every febrile child, don't just get urines. Think about the likelihood the child has a UTI, and we've spoken about all the different things that might lead you to think this child needs a UTI considered. And then if you do consider it, think about the best way of getting a urine that minimizes contamination and obviously harm to the child, because you don't want to be doing invasive specimens on children that don't require them. Because if you don't get a proper specimen, you get unhelpful results. And obviously the sicker and younger they are, the more likely to send them to us, and we'll do something more invasive. And the same if they need urgent treatment, they'll be more invasive. But I would definitely say try and avoid the home specimens. I do, when people come to me, and it's not an offense to you, as you said, because you've described how the urine collection is in the GP side of things, and I know how it works in those labs. And they say, oh, I was diagnosed with a UTI 3 weeks ago with my GP. I'll make a specific point of phoning the lab and getting the actual results to have a look at it. Because I want to have a look and try and understand the timing of the collection, what the symptoms were, what the likelihood was, because I don't want to diagnose or label a child as UTI because of what their future holds if they're labeled as UTI, previous UTI. Look after I'm sure you all have dipsticks in your departments. You can certainly do them, by just looking with your eye. You don't need a machine. If you have a machine, make sure it's calibrated regularly. If you do store them in your room, make sure the people that look after it know that it's got a desiccant in there, and the lid has to be kept on to prevent oxidation, humidity damaging it. Otherwise, they're useless. But they're actually very helpful, and there are a number of studies showing how they are very sensitive, in that if they're negative, it's highly unlikely you have a UTI because the white cells are negative, except in the under 3-month-olds. And then I wouldn't be sending the urine in any negative dipstick. And the positive ones, you've got to look at the positivity, how positive, and how does it relate to what's in front of you. And remember, positive nitrites on their own are of no value. They need to be accompanied by leukocytes. And then just to understand the culture interpretation. There's got to be white cells. You've got to have a count greater than 10 to the 8. It's got to be an organism that you associate with infection. And just be aware, the same is with the elderly. You'll be dealing with the same thing. All those elderly women in nursing homes that Ivor Katz is dealing with, that are getting treated over and over again because of positive urine specimens that are all got asymptomatic bacteriuria. So children can have it too. So just understand that culture positive doesn't mean that it wasn't actually an infectious damaging organism.
Thanks, Donovan. This is
okay.
a great topic. I'm going to let you have 2 more questions, and then we're going to finish. The one question is, would you put a cotton wool at urethra on a nappy and send the cotton wool in a yellow top jar to the lab in females?
And my answer there would be no. My cotton wool will still get contaminated by skin organisms and perineal organisms, but it's really there to screen for the presence of leukocytes, which are unlikely to be present just on skin. So it'll come from the urine and allow me to decide if it's negative, that's where I'll stop. But if it's positive, it doesn't mean that I'm necessarily going to go for an invasive specimen, but I'm going to have to think hard about whether I'm going to do an invasive specimen or try and get a clean catch, depending on the age of the child. If it's a 6-month-old, for example, with a positive cotton wool specimen, then I'm going to be probably going for an in-out catheter. But if it's a 2.5-year-old with a positive one, then I'm going to ask the parents to really try their best to get a midstream specimen, particularly if it's a male with appropriate perineal cleaning, because I'm not going to try and do a catheter specimen in a 2.5-year-old male. So, you can see how it's very dependent on what's in front of you.
Okay,
But I would not send the cotton wool because they'll be contaminated like the urine bags are.
There's another one from Nancy saying, urinalysis strip. Which results are more likely, UTI in routine analysis strips? Please, I'm not sure I've understood that question clearly. I'll give you the other one. Can we diagnose UTI with leukocytes only without nitrites? I think you
100%.
suggested if there were symptoms and in the right clinical associated features.
Yeah, because sometimes you're not treating pyelonephritis, you're treating cystitis or urethritis, and the bacteria that are in your urethra may not have produced nitrites. They're not dwelling in urine, they're just starting to ascend and cause local symptoms. And you may well just have white cells without nitrites. So nitrites are helpful as another positive predictive value that there's a bacteria growing there. But the fact that they're not present doesn't mean there isn't a bacteria growing there, even a nitrite producing one, particularly if the urine hasn't been there long enough, or if it's in an area where they don't sit and dwell and have time to cleave nitrites into nitrites.
Okay, so judge signs by the company they keep. So how reliable that is, no false positives on clean clutch urines, SPT in out catheters. Should GPs be doing in-out catheters in the rooms? I think you answered no to that.
Yeah, I think that's very difficult for you. It's traumatic. I think even experienced nurses struggle to always find the urethra in baby girls. And, getting through a foreskin in a young boy can be quite traumatic. I don't think that's something that you need to put on a busy practice. I think it's definitely something and the sort of age group that often need, to be held and the parents need to be supported. And we have a team that can do that, and you don't have that luxury.
Right. Okay. When you say urinalysis, are leukocytes the most valuable thing, or nitrites, or less proteins? And if they're all negative, how many do you or you don't have UTI? What if leukocytes and nitrites are positive? I think you've answered
Yeah,
this
some
to
of them might have been
some
asked
degree.
earlier before I went into that, because I think those were questions that came through before I went
Okay.
through,
We'll
that I
take
think the
that
higher the
bundle.
leukocyte count, the higher the chance with the right story, not just a random urine, with the right story, the higher the leukocyte count, the more likely there's UTI. Nitrites add positive predictive value to that. But nitrites on their own don't really have any value.
Okay, there was somebody who mentioned this, I suppose there's crossover with other questions around Giardia, so sort of other causes. They found a patient with Dientamoeba fragilis on the culture, and they treated it and all the symptoms resolved, which were poor appetite, abdominal pain, and not eating.
Yeah, Dientamoeba is another parasite, but it's a very interesting one because it tends to be found in a lot of asymptomatic people too. So a lot of the ID guys and microbiologists don't really know what to make of it. I think if people are symptomatic, they'll say treat it, but if it's just a finding in somebody, you wouldn't necessarily do anything about it.
Okay, so that patient had diarrhea, so you probably would be treating it.
Yeah.
So then there was another one. What happened to Fasigen? It's unavailable now, but many
Yeah.
don't tolerate metronidazole, especially older kids.
Yes, I used to love Fasigen. So that was tinidazole, 2 grams, and if people could tolerate it, particularly over 12 years of age and adults, it was a one-off treatment for both Giardia and Trichomonas vaginalis. So it was a very good treatment for different things, and I don't know why it disappeared, but you can't get it anymore. Probably 2 years, 3 years since I've been able to find it anywhere.
There's been a few questions around sending the urine with the couriers and with the pathology companies. What's your feeling about that, I think there's quite a few questions. The next two sort of deal with that, the labs and the
Yeah,
urine.
and that's the hard thing for you because, and that's why I wanted to mention this because I don't think people appreciate how these bacteria that are contaminants grow when they stored at room temperature. And so ideally the lab should collect within 4 hours and you should have a refrigerator. We've got them in both our EDs now, the store urines that we're thinking about, but we haven't sent straight away. So, and the lab should pick it up and put it into an ice box, to inhibit growth of contaminants before it gets plated. But it is a big problem, and I think it's one of the reasons why there might be, higher incidence. But again, if you screen appropriately clinically and with your dipsticks, you're not likely to send those urines.
Right. Okay. So I think you've answered the next one about no nitrites and leukocytes. I think we've covered that quite a bit. Then there was just somebody asked that question about E. coli sensitive to trimethoprim and another E. coli resistant to trimethoprim. They said the same organism, one sensitive and one's resistant to the same antibiotic. I'm assuming they're asking, what does that mean?
Yeah, I don't think you or I could answer that. I think a microbiologist would have to answer that. I mean, some of the features of contaminant are, different organisms in cereal urines, and I guess different organisms that have the same organism with different sensitivities probably represents two different organisms. You can definitely have two E. coli species uh, in the same person that are sensitive and not sensitive to different things. That's what I would say. I'm not an
Yeah.
expert in that area, but that's what I would surmise.
So
And
I would agree. You can answer this if this is for children, but certainly trimethoprim is one of those antibiotics I really only use in the mildest, safest people with no no sort of comorbidities. Generally, it's not the best antibiotic, and one should be using others.
Yeah.
Is that the same for you?
Yeah, same.
Okay.
I mean, trimethoprim kids is a little bit trickier. We just generally go Keflex first line anyway, and then go for the sensitivities after that. This is not a bad thing for you guys to screenshot if you want. This is the pathway we sort of use for choosing who gets a urine that we want for culture. And it sort of summarizes everything that I've done. The group that we choose, how we choose them, how we get the urine from them, what the tests mean, and then when we decide to send. So that's not a bad screenshot. That'll probably also help answer and summarize a bit of what I've been talking about.
Okay, I think you've discussed about putting it in the fridges. Pediatric bags in babies, is this a better way of collecting urine from?
So it can be a
That's
reasonable way to screen. It's only helpful if it's negative. If it's positive, it's got a 60% contamination rate. So then it's useless. And it's a good thing if you want to see if a child's got diarrhea and they are passing urine because they're dehydrated. So we use them sometimes to make sure there's urine being passed. And, if you need to get a urine for other reasons in a child that might be difficult, other than infection screening, then it's reasonable. But don't use urine bags for culture because they're highly contaminated. The urine just, sits there bathing in the perineum.
So can I get a sense that if people, however they test it, if it's positive and they need to do an invasive sort of investigation, they probably should save that for the ED or for the pediatrician. Is that in principle?
Yeah, I think that's reasonable. And I think, because I think what will happen is a lot of the toddlers they're dealing with, they'll be able to get a specimen by just educating the parents once they've done a screening test or best specimen they can get. And if it's negative, just stop there. And the ones that they screen, they could, do the cotton wool and the nappy thing unless they're worried about them. And if they came back positive, they send them to us and then we go from there. But they'd probably find 80% of those kids they put cotton wool on the nappy with, it'll be negative, and they could say, well, we don't have to necessarily think about a UTI on this patient. But again, it does rely on the dipsticks being not fatigued and stressed and looked after and interpreting it correctly.
Right. So look, I think we're going to finish off. They've asked for your summary, which we'll make sure they do. I think we've asked some questions about trimethoprim. And I think many of the others just saying thank you for your knowledge and your expertise, greatly appreciated. And there were a few other questions about bacteria. I think probably in the future we need to get the ID team here to talk about diarrhea.
No, hey, just I'm probably opening up a few can of worms I can't defend. But feel free to email me, donovan.dwyer@health, and I'm very happy to entertain and try and answer your questions. I'm not saying I'll know it, but I'm also happy to learn from you.
Thank you, Donovan. I think we can see your great expertise in this area, and there's tons of questions and interest. Thank you, everybody, for participating and for participating in the integrated care sort of lecture series, and for Bertha and support from the PHN. It's really much appreciated. I think it's a great opportunity for us to demonstrate the great specialists that we have in our hospital services. And it's St. George and Sutherland, and you certainly fall into that category. Thanks, Donovan. Thanks for joining us tonight.
Thank you. Thanks all.
Thanks, everybody.
Cheers.
Thank you, everybody, for joining us tonight. Dr. Dwyer, thanks for your time and your incredible knowledge. We'll send through the questions to you. And then when you get a chance, if you can send back the answers, and we can share that with the attendees. And also, if you're happy to share your presentation, we can send that out as a PDF. Thank you to everybody for attending and for staying a little bit later tonight to get through the questions. Ivor and Kylie as well for organising all the speakers throughout the year. This is our final session for 2024 with St. George Hospital, and we look forward to seeing you again in March when we kick off the series again. So thanks, everybody. Don't forget to complete the questionnaire, and we'll see you at the next event. Thank you.
Thank you. Cheers.